Ahuja, who is a consultant spine surgeon at the Spire Cardiff Hospital, Cardiff, UK. And along with him is Dr. Ankur Nanda, who is also a senior spine consultant at the Indian Spinal Injury Center in New Delhi. All of you are aware of the disease Ankylosing Spondylitis. It's an inflammatory, this progressive inflammation of joints, which is very episodic. The disease typically begins in the sacroiliac joint, progresses into the lumbar spine, the thoracic spine, and finally into the cervical spine. When each episode goes down and the inflammation settles with a little bit more of stiffness, eventually resulting in a fused spine. These patients usually land up with a thoracolumbar kyphotic deformity. The disease typically begins when the patient is 18 or 20 and gets burnt out by the time the patient is about 45. Patients with ankylosing spondylitis, though there is new bone formation, the quality of bone is extremely poor and weak, and therefore are more prone to fractures. Additionally, there is this huge bamboo spine, so that if there is a trauma, there are long lever arms on either side. So these fractures are extremely dangerous and refuse to heal on their own. Today, as a part of this webinar, we are going to discuss various types of spinal injuries in ankylosing spondylitis. I would like to invite Dr. Ankur Nanda to share the first case with us, and we go from there. It's going to be an interactive case-based discussion session, and you are free to ask questions to us. Stop us in between if there is any question that you would like to answer. I will stop sharing my screen and hand it over to Ankur. Ankur, please start your screen.
Thank you, Dr. Gautam sir. It's really a pleasure and honor to be here and sharing the screen with stalwarts like yourself and Dr. Sashin from UK. So if I can just I'm just pulling out my slides. So I'll be speaking on a fracture in ankylosing spondylitis, and just a sec. I just need to declutter my screen a little bit. Yeah, so now it should come. Are my slides visible now?
Yes.
Yeah, okay. So we are talking about spinal injuries in ankylosing spondylitis, and we know that the changes of ankylosing spondylitis in spine, actually they start with an inflammatory granulation tissue at the junction of annulus fibrosus and the vertebra, and gradually it replaces the annular fibers which have been eroded by bone, leading to syndesmophytes formation across the vertebral bodies, and it leads to the formation of something which we all know as the bamboo spine. And why it's important to understand is because this is the reason why we deal with the fractures of ankylosing spondylitis the way they present. Biomechanically, the fused spine is more like a long bone fracture or a shaft femur, and whenever there is a fracture which happens through one of these segments, it acts as it has a very long lever arm, and so it is incapable of appropriately dissipating the energy of the trauma, and hence it would keep on moving and has a poor healing potential. These altered biomechanics combined with the osteoporotic bone will increase the chances of the fracture to happen, and at the same time impaired rigid spine with peripheral arthritis and gait unsteadiness leads to frequent falls in these patients, and this is the reason why we see these fractures which are very difficult to heal. Now, fractures in ankylosing spondylitis has been very well studied and presented in the literature, and there are a number of things which differ from a normal trauma. So from a normal trauma as compared to a normal trauma, the ankylosing spondylitis fractures are very commonly missed, they are more hyper, and we will look into the fact why it happens as we sort of talk to our eminent panelists here. Also, they are more having commonly a hyperextension fracture pattern. The cervical spine fractures are more common than the thoracolumbar fractures. The prevalence is between in the CT junction area between C5 and C7. Non-contiguous injuries are estimated at almost 10%. Epidermal hematomas are also quite common with these injuries on almost 10% of the patients, and neurological deficits are encountered in 21 to 100% of the patients. That has been reported. Mortality rate at 1 year is also quite high, and there are other complications which are associated with these fractures like pneumonia, respiratory failure, and neurological deterioration. We'll just move on to the problems which we face with these fractures. I think one of the major problems probably with the ankylosing spondylitis which we face is positioning. So I'll just like to draw in my panelists here, and I'll probably start with Dr. Gautam. Dr. Gautam, how important is the positioning in a situation wherein we are suspecting a cervical trauma patient who comes into the emergency room? Do you give any special instructions to your fellows who are attending, or what is your biggest fear at that time?
In patients with ankylosing spondylitis, whenever there is trauma, it's almost always a 2-column injury. Both the anterior and posterior columns are gone. And the most common mode of injury is an extension distraction type of injury. So the spine opens up from the front. Now, in these patients, there is an inherent kyphosis. They are bent forwards. Now, if you make them lie down supine like you would normally any other patient, the spine actually goes into extension. So there is a distraction or opening up at the front. And this distraction could actually result in a spinal cord injury. And therefore, it is vital that if the history is there, that there is a patient who is in ankylosing spondylitis, there is a history that this patient was kyphotic before the injury, then it is not normal for this patient to be in the supine position. What you need to do is to put a couple of pillows and recreate the normal kyphosis the patient had before the injury, so that the anterior part closes down and doesn't open up, reducing the risk of spinal cord injuries. There are papers in literature which have reported that the patient went into a MRI or CT scanner, and when they came out, they were, before going in, they were neurologically intact. When they came out, they were quadriplegic, and that was primarily because of improper positioning.
I think that's a very well brought out point, sir. I think for all our attendees and everybody who's sort of listening, positioning is so important even before surgery when the patient is in ER. And you can see in the photograph, this patient had an ankylosing spondylitis. He had ankylosing spondylitis along with a suspected fracture, and you can see how he has been placed in the CT. He has his cervical curvature and his thoracic curvature has been recreated because we don't want to add on. And Dr. Gautam is right in saying that there have been incidents wherein the patient has been taken up for CT with normal neurology and ended up being paraplegic. And since now we are talking about positioning, I'm going to jump a little bit off the gun, and I'm going to involve Dr. Sashin here and ask him if is the positioning less or even more challenging when you take them up for a surgical fixation or any surgical procedure. How do you manage these patients in positioning in preoperative scenario?
It depends on the type of fracture and which level we are looking at. But of course, when you have to position the patient, you want to keep them as normal to their alignment of the spine as you can, as you should. But it depends what sort of availability you have with regards tables, attachments. Like I remember a case I did in 2010, 2009, something where I was doing a lumbar osteotomy and I couldn't fit him on anything. This patient, I had to take the top end of the table off. His head was, I was looking for the photograph today. His head was absolutely over the top, and we had to rest it on a stool with nice gel pads on. Like this, yes, what you're showing, that was far worse. I was just looking for that image. I just couldn't find it today. Otherwise, I would have had that in my talk. But you're right, positioning is a challenge. But the more important bit that some people may not figure out, sometimes what happens is when you're positioning them, there is an issue with the neurology. I remember one case we had. For some reason, my colleague had monitoring on, and as soon as we positioned the patient, the monitoring started switching off. He would have made an incision and he had to stop and turn the patient back into their normal position again, and he had to abandon the procedure. So these are not easy fractures to deal with. So if you are dealing with these, make sure you have everything ready and you are cautious up to the umpteenth level to make sure you're doing it properly.
Uh, Thank you, Dr. Sashin. I think we have brought it out very correctly. It depends upon what site of fracture we are looking at. It depends upon where exactly the fracture is there. And I've just put these photographs up just to sort of, highlight the point that whenever we have an ankylosing spondylitis patient, be it for a trauma or for deformity, positioning is something which is very, very vital. And there is no table made for every ankylosing spondylitis patient. So you have to be ready with your local jugards, with your gadgets, with your Mayfield clamps, with your extra sheets, cotton rolls, and you have to make sure that you are sort of working like a carpenter maybe, and realigning that patient and in the prone position. And the biggest dreaded probably preoperative complication, as I may say, is in ankylosing spondylitis, that as you make them lie prone, they may really open up badly, and it may be very, very difficult to sort of close them down. So I think that's what it's about, positioning. The other problem which we face, and I was talking about just before when I was doing a little bit of a literature review, is the high rate of missed diagnosis. So I'll just like to sort of involve Gautam sir here. Sir, why do you think there is such a difference in high rate of misdiagnosis, ankylosing fractures versus normal fractures? If you could highlight.
I think three reasons which would come immediately to mind. The first of which is patients with ankylosing spondylitis get injured even with a minor trauma. So even falling from standing height, like you would get an osteoporotic vertebral fracture, you can get quite a significant cervical or thoracic injury. And people would not imagine that these patients would have a significant fracture because they've had they've gotten up after the fall and started walking. The other thing being that these patients, because of ankylosing spondylitis, have had pain, inflammatory pain for a number of years. So their pain thresholds are much higher and they can tolerate this pain better than other patients. The other part is this bone abnormality there is a lot of bony abnormality here. And therefore, to be able to diagnose sometimes is far more difficult. And therefore, if there is any suspicion, if a patient with ankylosing spondylitis comes to you with fresh onset pain after a fall, it is vital that you do not ignore it and you get a CT scan done in order to diagnose the problem, because you should have a good radiologist, and the spine surgeon himself should be experienced to be able to diagnose this problem, because often the anatomy is very abnormal. There is a lot of overlap of tissues because of the kyphosis, and you may not see. Finally, at C7 T1, the most common injuries are in the lower cervical spine. And in the lower cervical spine is often not clear because of the kyphosis they have. So all these reasons put together result in a lot of patients injuries being missed primarily in ankylosing spondylitis.
Absolutely, sir. So I think the takeaway here is, whenever you have an ankylosed patient, don't rely on the X-ray which you are able to see. Usually the X-rays have poor visibility, and probably the CT becomes the preferred choice. So with this preamble, probably we would, go on to the case. So I'm presenting a case here. It's a little bit longish, and so this patient was a 43-year-old male. He had a road traffic accident 3 months back. He was a known case of ankylosing spondylitis, and he was diagnosed with a fracture of C7T1 area. As we were just discussing, it's the most common area to happen. But along with that, he had a non-contiguous fracture at the D9, D10 level. His neurology at that time was AISB, which means his sensations were intact, but motor power below the level of injury was gone. And he came to me with an already being operated 3 months back, wherein an ACDF was done. and a fracture D9, D10 was managed conservatively. And he came to us now 3 months down the line. And this was his X-ray on day 1 after the surgery was done for the fracture at C71. So this was the initial fracture, initial X-ray they came with. So any comments on this, Dr. Sashin? Would you like to make a comment? It was a C71 injury, 3-column injury. I'm so sorry that I don't have the pre-op MRI, X-rays or anything, but it was a 3-column injury with an AISB neurology. So any comments on the present situation?
I can't see the cervicothoracic junction very clearly, but
yeah,
from what I can see, looking at the plate, if the plate is sitting anterior properly on the vertebral body, the alignment, obviously you can't comment on the alignment at all on that. It'd be very wrong to comment on the alignment on that. So I would like to have a CT properly to see what's happened there. But generally speaking, depending is there any pre-op imaging available prior to this fixation?
So prior to this fixation, sir, so actually the patient got operated there immediately after the injury, and this was the X-ray done 2nd or 3rd day post-op.
But do you have anything prior to that?
No, nothing available prior to that. But if I can sort of add on to the discussion and help in the discussion, it was an undisplaced fracture with a 3-column injury. And probably the decision was taken to stabilize it, with an
it'll be very easy to criticize the person who's done the operation by saying, why are they gone single level? Why didn't they go long? But without seeing those imaging, it will be unfair to criticize the person, because you need to see exactly what the fracture is. We may call it 3-column, we may call it whatever we want, but we don't have that image to comment on that specifically. Yes, the general dictum is that go long. As Gautam mentioned earlier, they are long lever arms, because it's a chalk stick fracture, isn't it? So you've got a big piece of chalk at the top, a big piece of chalk at the bottom. You're trying to fix this. Like, we have fixed them single level and we've not had a problem. But I think to comment on this would be unfair without seeing all the previous imaging.
You've been very fair, Dr. Sashin. Thank you so much for your comments. Dr. Gautam, any comments on undertaking an ACDF at a in an ankylosing spine in the cervicothoracic junction? Would you?
I will share, Ankur, my experience. There was a patient of mine, an elderly 72-year-old gentleman who had a similar fracture at C6, I think 5-6, and in ankylosing spondylitis, I went in and I was very frightened to turn. Sashin mentioned the problems with positioning. So I was very frightened to turn the patient because I felt that it may displace further and all. So I decided to go anteriorly just so that I can stabilize, and then go posteriorly and stabilize this patient around so that I could turn him safely. I went in from the front and I actually did a long anterior fixation. So not like this. I did a two level screws above and 2 below, and I was quite happy with the fixation. When I turned the patient around, and I had a image at the end of the surgery which showed that the fixation was very good. When I turned the patient around and positioned the patient in the prone position, the plate had already come off. And what happens in ankylosing spondylitis is that the bone anteriorly is quite osteoporotic, and often your screws will not have a good hold. Number 2 is that it's a long lever arm on both sides, and therefore an anterior plate, which is essentially a buttress plate, cannot prevent shear forces and is more likely to fail. So purely anterior fixation is generally not the preferred option in an ankylosing spondylitis patient. Generally the preferred option is a posterior surgery, because it gives you a better fixation, and along with that you may SOS think about anterior. So posterior is today, the recommendation for this is almost compulsorily posterior, SOS anterior, and that is the way I would have gone for this today.
I mean, just to add on to the discussion, sir, let's say if this was not an acute trauma situation, but something like an Idolsom lesion, then would you consider an ACDF at that point?
No, certainly not. In an Idolsom lesion, even more so, because this is a pseudoarthrosis. There is mobility. Both the columns are gone. The anterior column is gone. The posterior column is gone. So today, the treatment of choice for an anterior lesion would be a long posterior fixation. And if because of the positioning, you have not been able to get a closure anteriorly, then you might want to go ahead and do an anterior grafting. If you manage to close it well with positioning, you may not need to do an anterior surgery altogether.
Okay, so just wanted to add to the information about the case, Dr. Sashin. So the history given by the relatives was that when the fracture had happened, his legs were moving at that time. One of the legs was moving, the other leg was not moving. So I assume probably it would be a aligned, well-aligned fracture. This was the immediate post-op, but and it looked quite well-aligned immediate post-op. But and this was the fracture in the thoracic area, somewhere around the D9, D10 area, which was conserved by the primary team operating. When they, this was the fracture. So when the patient came to us, this was his clinical situation. He had tenderness at C7, T1 area. He had history of dysphagia. He was a heavy smoker. He had hyperreflexia in the lower limbs. Upper limb power was normal. Except C8 and T1, which was around 3/5. So grip was weak, finger abductions were a little weak. Sensations were present all throughout, but were decreased or blunted below D4. Bowel bladder was involved. Planters were extensor. And this is how his MRI looked at that time.
Yeah, again, like, I'm surprised they managed to get into the cervicothoracic junction. If somebody's ankylosed, the neck is further forwards. In normal situation, get to C7T1 can be tricky, especially in our part of the world where you've got a lot of people who are well-built, short necks, very muscular. So I'm I'm genuinely surprised that they got into it so comfortably. It's again, seeing the pre-op. Of course, you look at this and you go completely the wrong decision. What was done, and of course it's failed. But looking at the first imaging to see what was there, I know we don't have it, would give you
Would be
some sort
critical.
of an idea what was happening. And generally speaking, if you have such a long, if you have such a significant injury, you may end up doing a front back anyway. So it all depends on how the patient wants to start off. The patient has got typical central cord syndrome now, as you see from what you're talking about in neurology. In relative terms, that lower thoracic fracture, in a way, yes, is unstable, but from a neurological point of view, is meaningless because all the damage has been done proximally.
Sure. So this is how. So what had happened is, if I can just sort of describe the findings, I think the plate had sort of got detached from the lower part of the spine. The C7 had completely shifted over and had now moved to the front of T1 by that time. And the fracture had probably, thoracic fracture had not moved much, maybe opened up a little bit than previously. So remind you, this is 3 months down the line. This is how the whole spine x-rays were. This was her axials. This is how the CT looked like when we did the CT. And we can see that the screw and the plate lower part was almost hanging in the midair. Yeah, so let me just check if I have any more. Yes. So, Dr. Gautam, what are your thoughts at this point of time? So let me just summarize quickly. It's a 3-month-old injury. Patient initially at the time of injury was moving legs, but over the time has stopped moving legs. His lower limb power is 0. Upper limb power is 5/5, except C8T1, which is 3/5. Sensations and perianal sensation is present. And he's a young smoker, 43 years old. So what would you think at this point of time, sir?
So I think our problems are fairly straightforward. There is a instability of the spine with a failed implant over there, and there is a neurologic deficit proximally. There is in the distal lesion there is a just a instability of the spine. So how do we treat this? I think, as Sashin mentioned, from the neurological aspect, 3 months down the line, is the patient going to really recover neurologically? Very, very doubtful. But still, I think I would want to give a chance to the patient and realign the spine as well as possible and stabilize the spine as well as possible. So what would be my approach here? I think I'm not sure that circle which you have shown in the middle image, whether it shows some kind of a fusion happening over there between the C7 and T1 anteriorly. I'm not sure. But what
It wasn't. It wasn't,
I
sir.
would do is a traction. I would put the patient on skull traction within kyphosis and try to gently, with a carefully neuro monitoring is not much use, but you could help use it. But basically, the patient is awake. It's in the ICU. You are looking at the patient every 15 minutes or half an hour or 1 hour. You keep on increasing the weight and see how it goes. If you can distract it a little bit and partially reduce it, with traction, it will make your job a lot easier going in there. Once that has been done, then the next job is, of course, to go in and if you've partially reduced it, I would be happy to go in posteriorly, stabilize the spine. I would go at least 3 levels above and 3 levels below the fracture line. And I would decompress from the back also. And then at a second stage, I would go in, remove the plate from the front, and then if it is necessary, do a replating in the front, attempting to fuse that in a non-reduced position. If the problem with trying to reduce it fully is that this plate will come in the way of the reduction, and therefore, if you are going to do the partial reduction, it will still be possible to do that, and then you fuse it in that position. The other alternative is to go anteriorly, remove the plate, then put the patient on a traction for a few days, try to realign the spine as well as possible and do a posterior stabilization.
Sure, sir. I think you have covered a lot of this thing. Dr. Sashin, your opinion on traction in ankylosing spondylitis. Are you comfortable with it? Do you find it very anxious, or at 3 months, are you expecting anything?
With an awake patient, I'm not anxious. The patient will tell us what's going on. Traction otherwise can be an issue, but like you would do for any, say, locked facets, things like that, because the patient's awake, you're gradually increasing the weight. The important thing is the position and the alignment, because for some reason the CT looks far worse than the MR. Can we just go back to the MR, the previous slide? Yeah, no. So yeah, so that's the issue with regards the traction. So yes, although we call this, if you look, he's not that kyphotic. He's more kyphotic at the lumbar spine, and I don't know. It's a very strange sort of an appearance for the angstpond. Although he is angstpond, there's no question about that. But he's maintained his like cervical lordosis very well. He's not kyphosed that much in this thoracic spine. But as I said, you'll have to keep him in line to his thoracic spine, where the head should sit, rather than in line with the cervical spine itself, because that's going to dictate where his head goes.
Sashin, would you at all consider over here that you would just go from the back, stabilize 3, 4, whatever levels above and below, and decompress the spine, let the C7 T1 fuse in the dislocated position? Once you have decompressed, it really doesn't matter.
No, I agree. That may be, your hands may be tied. Okay, he's a young man, but sometimes if he is not very well, his chest is bad, you're limited with what you can do. I think just traction would be the best thing to do initially, and then bide your time, let things settle, and then gradually you pull him out. Yeah, I agree with your point, whether we take the plate out initially or do it, but this is going to take a while. It's not going to happen straight away, because even traction, you may need to keep the traction on for at least a fortnight or so, if not more, because you're going to gradually stretch him out. But I agree with your point, Gautam, when you mentioned that between C7 and T1, you could just see a bony bridge, although we're being reassured that wasn't the case. But that would give you a little bit of concern how much you'll be able to pull him out.
So I think the concerns raised by both the eminent panelists are absolutely correct, and you have brought in all the dichotomies which were going through my mind. And we did give him traction, although I have to be honest, we didn't give him for a fortnight. We gave him for 2 to 3 days, and that was the time when I was trying to get my thoughts together. What am I going to do? And in those 3 days, we didn't see anything moving. The CT scan was a little confusing whether it's fused or not fused. And so we decided to sort of go ahead and take the plunge. And the plan was to do an anterior first, because as Gautam sir rightly pointed out, the plate would have been a hindrance to get a complete reduction. And I was trying and hoping to get a complete reduction from that fracture. So we went ahead, we did an anterior corpectomy actually of C7 along with the plate, and we wanted to get the posterior translation out. But although we got the plate out and we removed the vertebral body because it was not mobile at all, when we went posteriorly, we tried to do 3 up and 3 down. And when we were trying to reduce after getting all the lateral masses and everything out, actually my screw started to pull out between 4 and 5. And the bone was not holding well. So I had to, re-implant and go up to C2 to get some good purchase. So I, changed the strategy, went up to C2, got a better purchase there. I did my laminectomy, and I could only, bring it to a little bit of bone and bone touching. Frankly, this has not reduced. It has reduced only by, I would say, 10 to 15% of the vertebral body. No matter how much we tried, we couldn't manage it. And that's why, the amount of curvature of the tapered rod, although we did a thorough laminectomy and decompression, this is what we had got. It was a very long surgery for me, tough one. I got my colleagues' help also, but this is what we could manage with that. At the same time, on a second day, we also fixed up the thoracic spine area. We managed to close the gap a bit because we tried some reduction screws and kyphotic rod. We managed to create the gap. God was kind because the patient started moving his toes on day 1. He was started on active rehab. There was further increase in the motor power in the lower limbs. But to be honest, there was a lot of spasticity as well. So whether it was really a very good power or was it more with the spasticity, I would think it was both. But there was definite voluntary contractions of the toes, and later on, he also regained his bowel and bladder. His voluntary anal contracture came back. But our happiness, was not so long, because 2 months later, while he was in our institute going under rehab, he said that he had increased pain in the leg since a couple of days. He had feeling of weakness in the foot again, and he heard a clicking sound in the rehab around 48 hours before he started complaining to us. So any thoughts on what must have happened? Dr. Gautam, would you like to make a comment?
Well, can you go back to your X-ray post-op, please? Yeah, the cervix. So, Ankur, I think this was a very challenging case and you've done a fantastic job here. But I would suggest one thing over here only, is that when you are attempting deformity correction in osteoporotic bone, it is vital to put pedicle screws in the cervical spine and not lateral mass screws. So if at all, if I was to go, criticize you for something after doing such a wonderful job that you have done, I would have said that you should have tried to get in some pedicle screws, because that would have certainly helped your reduction much better. But proof, as I said, that you don't need pressure and stabilize it in situ. The patient has like the pain in the cervical spine, so whatever lumbar spine, it's not in the cervical spine. Remember that aggressive rehabilitation is not a great thing in ankylosing spondylitis, because the bones are so weak that they can crack at any time. In fact, I have not had this, but there is one of my colleagues in Bombay had a patient who had a single solitary cervical fracture or something, but while positioning the patient in the prone position, the patient actually developed a fresh thoracic fracture, which was not realized intraoperatively. When post-operatively patient started complaining of back pain, that was the time they realized that the patient had a fresh fracture. Now, the fracture that you are showing, I was going to comment about it in the preoperative X-ray. Please go back to the preoperative X-ray. Go one back. X-ray, not MRI.
I think, yeah, okay.
Can you see over here go, just remove this
Circle.
focus X-ray. Can you see the 2 level below there? There is a break in the continuity of the bone already over there. So there was possibly a break in the bone at that point, and it was a partial kind of an Anderson lesion which was there existing, and the lesion was completed during the physiotherapy probably. That's what I suspect.
So if you see the MRI, sir, actually there is no break at that point of time, but that is one unfused area. So it was fused on behind, but there was a unfused disc on the front. So this is his MRI pre-op only. So as you said, during the rehab, because he had a lot of spasticity, there was a lot of stretching going on, and he developed that click. And now you can clearly see on the posterior end also, sir, there is a fracture which has extended into the posterior elements. And this is what we ended up with. So Dr. Sashin, would you at this point of time go ahead and do something, or would you like to conserve him, considering that his partial neurology, he's really not walking as of now? Or would you go ahead and just go and fix it up as well?
No. Did you image him any further? Did you do a CT or MR again, just to visualize this a little bit better?
Okay. I think we have done it, but unfortunately, I think I have not put the slide. Because the story is a little long, so I didn't dwell on it much. So I don't have the MRI or CT of that. But
The
it was
issue is
definitely
what you want to achieve. Like, the alignment there seems reasonable. He's opened up a little bit. He's gone into a bit of extension. You've done lumbar osteotomy for him, partly. They do tend to heal. We've seen some of the posterior elements heal up really nicely in patients who we've managed conservatively. And the way our rehab guys work with us, they wouldn't get this patient up because of the spinal cord injury. They would keep them flat for 6 weeks. Our guys work on the oswistry protocol, which is a bit annoying sometimes from our end, but they take over the patient, they look after the patient eventually, so we don't tend to interfere too much with that. So if this patient was going to lay in bed, of course, you'll have to have a chat with the patient as well. This patient, unfortunately, has been through the hoops, isn't he? He's had a big op somewhere else. He's come back to you, ended up having a bigger operation and a bigger operation and another issue. So he's already ended up having, what, 4 operations? The first ACDF, the second plate removal, third posterior, and fourth posterior for his thoracic. So he's had 4 operations in a matter of 3.5, 4 months. So you need to look at all that. You could extend this down, but are you going to, if we go back on the MR, perhaps we just make sure there are no more open segments. If that is the case, you go all the way down and span it. It's not going to make a huge difference. Or you could easily treat this conservatively if the patient's going to stay in bed rest, which would potentially be the case at our center. And I may perhaps then in that situation just treat him non-operatively.
Point well taken, sir. Dr. Gautam, my situation was patient has started to recover. Everybody is very excited that, we may be able to get him back on his feet. We were doing a rehab. It's a complication created in the institute, by the institute. And would you like to, quickly take care of it, or would you defer? I mean, this was the, doubts which were going in the mind. How do I go about it?
So, whilst I agree with what Dr. Sashin has said, that this patient has undergone a lot of surgeries, he's debilitated, quadriplegic, partially recovering smoker, etc., etc. So he's not a great candidate for further intervention. However, in my experience, these fractures never heal, and so I on their own. So I have not seen what Sashin has seen. Maybe in my practice, these are patients who will eventually not heal, form a non-union. They may or may not displace, have back pain. So I would certainly err on the side of operating this patient.
So we did go ahead and we fused him. So we basically used got those last screws out. We got the dominoes in and we connected him, and we went down 2 levels more and fixed him up. Started mobilizing him. Again, the problem was during the surgery and positioning. He again opened up quite widely the lower area, because now there was nothing to compensate on the upper side. So you can see that actually, if in this fixation, you can see that the vertebra has actually translated a bit, and it has opened up more than what it was seen, in the pre-op X-ray. and we had real difficult in closing it down. So we did this surgery in the lateral position partially. Once we had inserted the screws, we got him into the lateral position to close a bit, and then applied the rods in lateral position, because in the prone position it was just opening up too wide. So this is after closing in the lateral position. Having done this, the patient went on to do well. I also decided to start him on injection teriparatide at this point of time, because now this was more of a osteoporotic fracture rather than a real trauma situation. And our experience while putting the screws, we thought that the bone was quite weak, he was fracturing. So I just wanted to avoid any further issues, and then I started him on teriparatide at this point of time. This was his 2-year follow-up after that. So we are now somewhere since 2.5 years, the primary surgery. And he came and he was complaining that there is some clicking sound coming. So right now, after 2.5 years, this is what his neurology was. He was with very great difficulty able to walk with walker, but his spasticity was really troubling him. There was a lot of spasticity still, plus his crouched posture because of ankylosing. But he was sort of very less ambulatory within the house with bowel and bladder continent, and he was saying that there was clicking sound on changing position since few weeks. And this is how his x-rays now look like. So you can see that there is an exuberant callus which you can see in the fracture area in the front, but the ominous signs were, you can see the INI has come out on the right side last screw, plus the second last screws you can see some halos around the screws. So the screws had started to loosen out, and you can see there was a big suit which was happening in the lower fracture side. The screw halos are clearly visible, and patient didn't have any deterioration in the neurology, but yeah, a lot of clicking sound and a lot of started to have pain. So this is what our situation was. Dr. Sashin, I'll start with you. At this point of time, so I know you advised me not to do surgery. Forgive me for the same, but this is where we are. But this is after 2.5 years of doing the extension.
Now I know you're in a tricky situation now. Look at that screw, what it has done. There is hardly any pedicle visualized. There's only a lateral thin rim. So there is no hold on that. Potentially there may not be a significant hold on the level below. So if you have to do something and span, you may end up going down to the sacrum. Once you go into the sacrum, then you'll have to start fixing the pelvis. Unfortunately, this is normal, isn't it? That's what we see. The more surgery we do, more complications we see. And I can tell you now, I go back to my point. If we had done this non-operatively, I disagree with Gautam on his viewpoint. I know maybe his experience is different. We have seen quite a few patients in whom, because see, they do tend to form bone, right? It's an enthesiopathy. That is the nature of the disease. And the disease throws, and especially if the patient is not being mobilized because of the spinal cord injury, which we are fortunate or unfortunate with what our rehab guys do for us, right? So in our setup, things may have been dealt with completely differently just because of the way the rehab guys would dictate what this patient would need purely from the neurological point of view. I know most of the other centers in the UK don't do that. They would get the patient going as and when we had just about managed to get them to agree that if the patient maintains their blood pressure reasonably well, we can start mobilizing them. Otherwise, it was a strict, hard and fast rule, 6 weeks, which was quite disappointing from our end. So no, it's going to be very tricky whatever you do now. I'll be interested to see what you've actually done.
Yeah, I'll show you, sir. And somebody came to help me for this. I'll share that. But Dr. Sachin, just to be the devil's advocate, see, I've done this. And so you're saying, see, I told you so, and this is not healing. But to be honest, you have to understand that this has happened 2 years, even after 2 years of the fixation holding and then loosening out. Probably if we had not fused him, the situation would have been the same, because this guy was a crazy smoker. And we know how smoking is something which will actually even reverse what ankylosing spondylitis is known to do, throw bone. Probably, So I have a strong feeling still that probably if we had not fixed him, we would have ended up doing the extension surgery much earlier than this. But I mean, I take your
No,
point,
I
sir.
do take your point. It's possible. It's possible. I'm not
Yeah.
saying it isn't. And I never said I told you. So don't these things. We've all made mistakes. We all
No, no,
look
it's
back,
okay.
a
Yeah.
retrospectoscope is such a good thing. We always look back and go, wish I had done it the other way. And it happens. These things, they're there to test you. And unfortunately, they are not these cases are few and far between, right? These sort of complications are few and far between. If these happened a lot more, we would be doing something which is pretty standard and pretty straightforward, rather than being talking about it and discussing it as to what we should be doing in these situations.
So bailout in this situation.
Ankur, bailout, I think, was done by me. I did the anterior fusion, isn't it?
Yes, yes, that's what I was going to say. Somebody came to
Now
help
I remembered this. I had come to Delhi and
Yes.
a course
So
and
it
I
was
did a live
it was the
demonstration of this.
yeah. So it was the SSI operative course wherein I had put this case to be demonstrated. And so what we did is we went ahead and we did an anterior for stage one ALIF, wherein Sir Dr. Gautam had done this anterior fusion for this patient. He went ahead and beautifully showed us how to do this approach, and the cage was put in. And Dr. Gautam, it's my pleasure to show you the follow up. So what we did is once you had done this, the next day we went down, we revised the screws, went down, got the screws in nicely. This was the distal extension. This is the 10-month follow-up. By 10 months, the bone had started to form nicely and consolidating. And this is his 4-year follow-up, total 8 years from the primary surgery, wherein it has solidly fused. The screws have went on to hold well. And yeah, so I think this is where my last slide is. So this is what we got. So we ended up fusing almost the whole of the spine once it started. So just from my side, I think takeaways would be adequate imaging is very, very important in the on the word go. Positioning is absolutely critical. Anterior instrumentation has its big disadvantages, and so we should be thinking of fusing long, at least 3 above and 3 below. Thank you so much, sir, and sorry for taking up so much of time, sir.
Ankur, before you sign off, just a quick question. With your extensive experience at the Indian Spinal Injuries Center in treating these kind of ankylosing spondylitis, when in these patients would you like to do an anterior fusion in addition? I mean, would you have considered now in retrospect, do you think you should have gone in and fused it anteriorly along with it? What is the gap, minimum gap which can, or maximum gap which can be left in the front without fusing?
So to be honest, I wouldn't be able to comment on the gap, to be honest. But what I feel is, sir, I think if you have risk factors wherein you feel that this patient doesn't have a healing potential, like in this patient he was really smoking, he was a 2 packs a day, around 20 to 30 cigarettes a day sort of scenario. I think the biology has to be considered. Otherwise, our experience with leaving big gaps in the front has been good. They go on to fuse and they don't create much trouble, as Dr. Sashin was also talking about. But I think the biology and smoking makes a huge difference.
I have another question, Sashin. Often in these kind of 3-column injuries which are highly unstable, you find the same scenario when you've done an osteotomy, a vertebral column resection. There is a huge risk of translation of the proximal column. How do you prevent that when you're reducing the deformity, kyphotic deformity?
So, like when you do your osteotomies, when you do your PSOs for correcting for forward gaze, when we've done lumbar osteotomy, we tend to put a temporary rod in, which prevents translation. And then you can gradually use the rod and contour the rod as you're correcting. Translation is a huge problem. In fact, I can say this very openly because this was discussed in our meeting here earlier in the year, where one of the patients had surgery, and the patient came and presented this in our meeting, where they had a translation on the table and ended up having neurological issues post-op. So it just goes. You got to be extremely careful how you deal with it. And a temporary rod is usually a very good technique to prevent translation, so at least it holds it for a little while whilst you're correcting it.
Thank you. Ankur, that was a wonderful case. So many learning points over here, and it was a fabulous case. Let me now invite Dr. Sashin Ahuja to come over and present his case. Sashin, would you share your screen, please? Just for the attendees, it is vital to know that this program is under the aegis of the Association of Spinal Surgeons of India and collaboration with Thieme Medical Publishers. And the ASSI, about 2 years ago, came up with a series of 9 monograms on various aspects of spine surgery. They have been extremely popular. We have sold more than 16,000 copies. They are available with TM on their Med1 platform, and they sell it as a whole bunch at a discounted rate if you are interested. Yes, Sashin, please carry on.
Sorry, I think I was on mute. So thanks for inviting me to speak about these dreaded fractures. I would call them dreaded fractures because they always throw some sort of a challenge when you're treating them. So, you see these injuries and you go, right, what is going to go wrong in this specific patient that you're going to be treating? So I just like to correct. I'm based in Cardiff. I'm in University Hospital of Wales, which is a major trauma center in the South Wales trauma network. Right. So ankylosing spondylitis, as we heard initially, what Gautam mentioned, is not an uncommon condition that we come across, and it's an enthesiopathy, and fractures happen after a very trivial injury, very low energy injuries that can cause a break. And generally speaking, a patient who's got ankylosing spondylitis who complains of any increasing pain, like you should get your alert systems on that this is potentially a fracture, and hence you should have a very high index of suspicion about it. Like with any other injury, you've got to looking at two different issues. One is a mechanical issue, and the other is the neurological issue, which can cause problems. And you've seen that in the previous case, how the mechanics gets disrupted and how the neurology can be affected. So that goes without saying for any spinal trauma. I don't need to go into the columns, but we generally tend to go with 2 columns, especially generally for all fractures. So most of the classifications currently are based on the 2-column theory. So usually these fractures are unstable. They are 2-column injuries. As we've heard, these are in long lever arms, and the risk of displacement is just something that we were discussing a few minutes ago. But don't forget, most of these patients are slightly the older age group. More so for us here. I'm not sure how the trends are back home, but generally here we are not seeing youngsters with fractures. We are not seeing patients with angspon with problems as such like we did when I had started as a consultant here in 2003. I used to do about maybe anything between 6 and 10 osteotomies for loss of forward gaze in patients. But since about 2012, 2013, I have done very few, purely the reason being how well ankylosing spondylitis is being treated, same as rheumatoid with the anti-TNF and all sort of medication that these patients are on. Their disease process is much better controlled. So we are not seeing that many youngsters with ankylosing spondylitis and problems related to it. So we are still seeing some of the older age group who come in and they have got associated comorbidities, and the risk of mortality is pretty high in these patients. And it is a challenge to keep them on bed rest and things like that because their chest goes off, lots of things happen. So it's not something that you would take lightly. And we just talked about some of the challenges like, the pre-existing deformity, challenges in conservative management. I was trying to find out that paper that we had come across in 2011 in the British Association of Spine Surgeons meeting in Edinburgh. and that won the best paper award, but for some reason that paper never got in press. And I think I should actually ping them an email or speak to them and find out what happened. And although we always talk about all ankylosing spondylitis patients to be treated operatively, and we should do long fixations, etc., etc., that paper, they had looked at a cohort of patients of ankylosing spondylitis with cervical spine fractures. They had about 39 odd patients in their study, and they showed that they could be adequately treated with a halo vest rather than needing a surgical stabilization, which completely was contradicting what I had learned, had seen, and had practiced. But that is the data that they showed us, which made us think that do we need to operate on all these patients? But we know managing them conservatively is a huge challenge. Positioning we've talked about, anterior approach to the lower cervical spine, generally speaking, a proper full-blown angstpon getting into the anterior part, lower part of the C-spine is quite challenging. The bone quality can be very tricky. I have seen angstpons where the bone quality has been good. I have seen ankylosing spondylitis where the cortex is thick as anything, right? You need a hammer to put your probe in to when you're putting the starter for your starter and the finder for the pedicle screw. But once it goes in, then perhaps there is not much of cancellous bone left. So, the bone can be like chalk and cheese, and I have come across that on quite a few occasions. So I'll just run through a few cases. A lot of principles and things have been covered in the previous case. So this is a patient, typical ankylosing spondylitis. You can see how the thoracic spine is kyphosed and the neck is going into the wrong direction, wrong position. Generally, in the cervical spine and in the thoracic spine, like you saw in the previous case, the injury goes through that mobile segment. The injury goes through that disc, and it may take a little bit of an end plate along with it. So you can see a little bit of end plate which is slivered off. The bone quality doesn't look that bad, and that in itself is given a patient an osteotomy, an opening wedge, anterior opening wedge osteotomy, improving the sagittal alignment for this patient. In this situation, this patient was about 86 years of age, and we didn't want to go in and do something really, you know, fantastic and wonderful, taking into account their comorbidities and everything. So we decided just to treat this with a halo, and this is the position we achieved in the halo, and she did well, and she was discharged to the nursing home. I don't know how long she survived after, but she had the halo on for about 3 months, and then we put her into a collar and transitioned into soft collar. This is another lady who is in her mid 80s, and if you see, she's crunched down the C6 vertebra there. She's got some posterior spinous process fractures, and on the axials, she did have some break in the lamina as well. But her alignment seems reasonable, and for this, we did not feel that we needed to go in and do an operation to fix her, trying to get into her from the front and then trying to fix her at the back. In an 86-year-old with the comorbidities that she had, we didn't fancy it that much. And this is how she was virtually 3 months down the line. You can see all the anterior bits have glued up quite reasonably well. And I was just looking at her images today. She came in, she's at this stage, she is 96. And about 2 years ago, she had a neck of femur fracture, which was treated. About 4 years ago, she had a tibial fracture, which was plated. So she is still around, doing reasonably well, despite having had a significant injury in her cervical spine. Although, compared to the previous x-rays and the previous cases that we've seen, her alignment doesn't look bad, and it's all more of a bony injury, which has healed up reasonably well. Not to forget, we're talking about ankylosing spondylitis, but I think we should take this opportunity to talk about the ankylosed spine. Dish being another condition that we come across, and you do see these issues in patients with dish as well. So don't forget the same analogy with dish, where there is that kyphosis of the thoracic spine, and the alignment of the spine should be in line with where the thoracic kyphosis is. And you can see the type of injuries that a patient from dish can sustain as well. So this was treated with an anterior approach, although we had to shave those osteophytes off quite significantly. This is the case that we published. So this is a chap who was shaving at home. He fell backwards, hit his head against the shower cubicle, and was walking around with pain for a few days and was just whinging all the time. I've got neck pain, I've got neck pain. And his wife got fed up of him and said, right, let's go to the hospital. About a week down the line. And they went into the hospital, and because he had neck pain, they weren't very sure what was going on. And typical, as we heard earlier, you try to do a cervical spine x-ray. Usually it's a lower cervical area where the problem is. And you can see here, there is some disruption. So 3, 4, 5, 6, 7. So 6, 7, there is some disruption. And you go, something is not right there. So this was in one of our feeder hospitals. And this is what they did. They did a CT and never realized what they had done. And they went on to get, so you can see what is happening there. The patient's already starting to sublux a little bit on both the sides and the lateral pillars. It went on to did an MRI on him, and still nobody picked up what was happening. And the patient started having respiratory issues and had to be admitted to the intensive care. We were informed about this patient, but this is the day and age where films weren't IEP'd. When you talk about these, that you can transfer the images electronically. Those days, the images would be sent 60 miles in a cab to us for us to have a look at the X-rays and send it back. But we knew that this patient had an unstable injury without seeing the images, and we accepted the patient. And this was an intensive care to intensive care transfer. And I went to see the patient, and the patient came to our intensive care, and I was coming straight to theatre from there. And when I saw this chap lying flat on the bed, like Gautam mentioned earlier, you would not have a patient with a good going ankylosing spondylitis lying flat in bed. Lying flat in bed means something is not right. And when I looked at the images, my jaw just dropped looking at it, saying, how can this patient be kept this way? This patient needs at least 2 or 3 pillows to have the head in line. Now, I know the ATLS manual talks about inline immobilization. Now, that inline immobilization is inline for that fracture. So if you see the thoracic spine, that's where the thoracic spine is. And if we draw the trajectory, the head should be sitting somewhere here, not there, right? So please remember that. I think that's a very, very important point. If you come across these patients in your emergency departments or wherever, make sure that they're in the correct alignment and they're not just put into a collar. But that's what happened. This guy was put into a collar, thinking that that is the correct position that the patient needs to be in. So we took him back to theatre, and guess what we would do, right? Let's ask this question to Gautam. Gautam, what would you do, please? Gautam, I can't hear you.
Sir, you are muted.
Yeah, so I would go the way you had suggested, Sashin, earlier, that you would start with the neuromonitoring even before the anesthesia. So you would start with the neuromonitoring before anesthesia, a fiber optic intubation, obviously, with the patient's neck flexed as much as possible so that the spinal alignment is recreated. And then position the patient very carefully, similar to what Ankur had shown in his picture, and then I would go in posteriorly. I would go in 3 to 4 levels below, 3 to 4 levels above, and stabilize the spine. If I'm able to close it completely in the front, or maybe leave just a small gap, I would stop at that. If the gap was significant, even after my instrumentation, then I might consider going an anterior fusion also.
Ankur, any thoughts?
Sir, similar to as sir said, I think the first thing would be to actually, even before reaching the OR, putting those pillows in, getting him to align, and then being very careful in positioning him. And then, long segment fixation for me as well. Posterior approach, prone position, and, keeping it in as much flexion as possible.
No, I agree, completely agree. So as I was walking to the intensive care, this patient was being wheeled out, and I was walking into theatre back with him. and he was already intubated, so he was tubed already because he was on a ventilator in the hospital. That's why he was in the intensive, because his respiratory issues were quite bad. And of course, we then put him in the correct alignment, having looked at what was happening, got him on the table. And people talk about floating hips and floating knees, not floating hips, floating elbows and floating knees. Uh, this was virtually a floating body, detached completely from the head. And when this patient was lying prone, and I'm not making this up, this is exactly what he was. With every breath that he was having with the anesthetic ventilating machine, his body was going up and down, and the neck was staying there purely because this was completely detached. We fixed him from the back. We did a long fix. We went three above, three below. But by the time we got him back to in his neutral alignment, the gap in the front didn't look that bad at all, right? Because that we had done, and we just fixed him from the back, and he woke up. So he was fairly okay, and he was moving his arms and his legs, which was good news for us. But his respiratory issues were so bad that virtually he was on the ward for a day or so, and then he went back to the intensive care, and unfortunately 10 days later he passed away. So we never got an opportunity to get a proper post-op x-ray done on him. I have got some intraoperative images, but they aren't that good to actually comment on it. But just trying to portray and say that these are not simple injuries that to deal with. These can be catastrophic and have got lots of problems. So just be mindful of that. So this is the article that we published in the ACTA in 2010. So if you want to have a look at it, in fact, if you go cervical spine and ankylosing spondylitis, I think this image comes up. So this one I think comes up on there. So that is the image from that paper. And I think that's all I have to say, because I think most of the things are already covered. Thank you.
Thank you, Sashin. That was a wonderful case, heartbreaking story. Patients with ankylosing spondylitis, as it is because of their rigid chest, have thoracic issues, have lung issues, and of course, if you have a cervical spine injury, that worsens the thing. I think the point was amply made here very clearly that you need to be able to need to understand this pathology, and you need to keep the spine, as Sashin mentioned, in its normal alignment, which is the alignment of that deformed spine. Sashin, did you do a decompression also, or did you do a stabilization alone?
No, we did decompress because I wasn't sure what his neurology was, because he walked into the hospital. So we weren't sure, because once he was put to sleep, what happened to him virtually from. So I think he came into the hospital about 4 in the evening, and he went off at about 8 o'clock at night. So virtually from 8 o'clock till the following day, 5 o'clock in the evening, when he came to us, we had no clue what was happening. So benefit of doubt, I just decompressed him just to be sure that we have given the cord enough room. So unfortunately, he didn't survive. That's the worst thing in this situation.
Thank you for presenting this case, Sashin. A great learning experience. I would like now the team from Thieme to give us an introduction to Thieme and what the type of books that they publish, the type of journals they publish, and how they will be useful to our delegates.
Thank you, Dr. Zaveri. Thank you, Dr. Sashin and Dr. Ankur for this wonderful presentation and the case-based discussion. I would introduce everyone here to our flagship neurosurgery platform. Could you please let me know if the screen is visible?
It's available. It's visible, Tinesh.
Okay, thank you so much. This Med1 Neurosurgery is our flagship product. It's the world's most comprehensive online neurosurgical resource. It is a powerful platform, perfect for residents and experienced specialists alike. So the users are. Give me a second. There's something wrong with the presentation. Yeah. So, Med1 Neurosurgery is a platform, basically it's for experienced specialists and wait a
Finish, we
second, I
can't
think.
still see your slides.
Okay. Just give me a second, sir. I'll reset it. Can you see the full screen, sir?
No,
Now?
no. We are getting a message that you are trying to share content, but the content is not being seen.
Okay. Let me just reshare it.
Could see the slides on our end.
Okay. Is it visible now?
Yeah, it's visible. You just need to go on slideshow and it'll be there.
Okay.
Yeah, it's
Yep.
there.
Okay, thank you. So, Med1 Neurosurgery is a powerful platform. It's for residents and experienced specialists alike. So users are provided with all-in-one access to continuously premier neurosurgical content. We have hundreds of ebooks, cases, procedures, plus thousands of images and videos that will be available on your fingertips. It additionally includes the Greenberg's Handbook of Neurosurgery, which is a must-have for neurosurgery. And this platform in total has 280 plus ebooks, 1700 videos, and 125,000 plus images. So overall, the content overview is that Med1 Neurosurgery has a fully searchable database with access to 280 plus premier neurosurgery ebooks, including Greenberg's 9th edition Handbook of Neurosurgery. We have a Q&A training center. We have full text e-journals, Thieme e-journals. We have a refined ebook view. There's a Med1 app where you can access the whole platform, and you can create your own playlist and access public playlists as well. And you can also take your own notes so that you can share it with your colleagues or residents or even for your students. So talking about ebooks, 280 plus ebooks are present in the platform as I discussed. We also have now books featuring from Indian authors and Indian medical societies. As Dr. Zaveri said, ASSI monographs is available as a part of Med1 Neurosurgery. And along with that, you can see other Indian books as well. So the training center contains 2,300 plus review questions. They are linked to Greenberg for daily need to know facts. So there are Q&As. You can refine your knowledge. You can gain more conceptual knowledge based on the training center. There are curated content collections based on common neurosurgical diseases and disorders. They're all in one place, so it'll be easier for you to access it. There are step-by-step instructions for 415 plus surgical procedures. So all kind of neurosurgical procedures. We have separate section for surgical procedures, so you can access them when you are subscribed to our product. There are management and follow-up tips for 220 plus cases as well. So today we had a case discussion, and Med1 Neurosurgery also has 220 plus cases for reading. Then there are the multimedia part. There are around 95,000 images and with legends and 1,700 plus videos which you can access. So and of course e-journals. We have Journal of Neurological Surgery and other journals which you can access once you get the full access of it. All the issues are available for our subscription-based journals as well. Searching is easy because it is highly sophisticated. So we have a very highly sophisticated search algorithm, and which ranks search terms by relevance across all the content sets that are available within the whole platform. This is the ebook view. Whenever you open an ebook, you can see on the left side there's a full TOC, and then there are images along with the search terms, and then the hits, the number of results that are coming from your search term. Here you can fill your search term, and you can access the whole ebook. You can adjust the font size, and on the sidebar there is also related content, so you can access that as well. You can download your own images, the images from Med1 to your own PowerPoint presentation using this feature. Once you click on an image, this feature will come and you can download those images. Of course, If you download the Med1 app, you will have mobile access, and you can access all the content for online and even offline use. And this app is available for iOS as well as Android. Talking about playlists, you can assemble your favorite Med1 content collections, upload content from Med1 and personal files, internet, private and public settings. You can create your own playlist with your own material as well. You can make this playlist even public for other people to access as well. You can select any text with your mouse in the window, and you can assign these categories, write a note on that, and click the save button. And of course, you'll have to log in for the same, but that's the feature that is given here. If you want to sign in, just have a trial access to Med1 for personal use, just to try it out. You can scan this QR code, and then you can access it. You can sign up for the trial, and you'll receive the access for Med1. For any other queries, please write to marketing@thieme.in. I'll share this in the chat box. So thank you from my end. Any questions to the panel, you can ask in the chat box.
Yeah, is this free?
No, sir.
All right. Thank you very much, Tinish. I think it's a great resource, and I'm sure a lot of our viewers today will be interested in. Can I share my talk?
Yes, sir, I can make you the presenter. Yes, sir, you can share.
I'm not seeing my presentation here. Yeah, okay. Can you see it now?
Yes, sir, it's showing that you're starting to share content.
Okay, let me see when my slide, let me know when my slide comes up.
It's there, sir.
All right, lovely. Can everybody see it? Yeah. All right. So we are going to the third case after these two very difficult and possibly horrendous cases. This is going to be a simpler one. This is Mrs. Ghiwala. She's a known case of ankylosing spondylitis in the last 20 years, has had a painless but a stiff, immobile back for the most of 15 years. Now she complains of severe pain in the back, which was spontaneous in the onset. There was no history of trauma or falls over the last 3 months. The pain is radiating along the anterior chest wall. Pain increases with movement and increases on sitting and standing. It is relieved in the supine position. There is no history of any lower limb radiation, no paresthesia, numbness, no history of any fever, weight loss, or anorexia. On examination, she had tenderness over the dorsal lumbar junction. The movements of the dorsal and lumbar spine were absent. Minimal cervical movements were present. The hip, shoulder, knee movements were normal. Chest expansion was restricted. TM joint movements were minimally restricted. No neurology. This was the X-ray picture which we saw. Ankur, let's jump straight over. What is this? What are we seeing over here?
So I think, sir, we can see that this is a X-ray of the middle thoracic to lower thoracic area, and we can see the spine is fused from pretty well fused in the upper thoracic area, and then in the lower thoracic area the anterior syndesmophytes are not so clearly visible, but still it looks fused in the AP. But there is a clear-cut unfused segment which is seen from between the last two ribs and the third last rib. So I assume this may be a T10, T11 or a T11 or a T9, T10 scenario where it is not fused in the front. Although on the X-ray, I don't see that it is not fused. It looks a little fused only in the X-ray. But yeah, the anterior segment is not fused, and there is some amount of erosion of the vertebral body is also seen on the lateral X-ray.
Yes. So is this she has no history of any fall. So is this a osteoporotic vertebral fracture, or is this some kind of you think there is an infection brewing over there, or what exactly is going on, you think?
So as we know that ankylosing is an inflammatory pathology in itself, and we know that when these there's something which is called as the Anderson's lesions, wherein there will be a inflammatory erosions of the vertebral end plates and the anterior the enthesitis areas, the corners of these vertebral bodies would start sort of eroding. So many a times, if you don't get an X-ray and just get directly the MRI done, you would start thinking that it's an infection, and we have seen it in the past being reported as infection. But this is more or less looking like an Anderson lesion or the inflammatory lesion in the spine.
Yeah, so I would agree. This is the diagnosis is fairly straightforward. We did get an MRI scan done, and you can see there is a break, which is the break which is there in the anterior part between the vertebral bodies, which Ankur mentioned is actually extending across posteriorly also across the fused mass at the back. And this break has typically occurred at the apex of the lower thoracic kyphosis, which is where it has happened. And this is what is called as an Anderson lesion, described by Olof Anderson, a Swedish radiologist back in 1937-38. It is most common in middle-aged men. Prevalence in ankylosing spondylitis is 5% to 28%. What is it? It's basically a destructive discovertebral lesion. It represents a vertebral pseudoarthrosis in the later stage. Radiology, you can see a reduction or enlargement of the disc space. The vertebral body defect is there with wide surrounding zone of sclerosis. There is a combination of bony hyperplasia and bony destruction, and there may be angular kyphosis at the affected segment. They are classified into two types. The type 1 is an inflammatory lesion. In this case, there is invasion of the disc by granulation tissue through defects in the end plates. This usually occurs at places where there is some preserved spinal mobility because of unfused facet joints. There is on X-ray, you find a reduction in disc space and a dense sclerosis of a cancellous bone because of a reactive sclerosis, what we would call. And it can be located anywhere in the spine, but is usually multiple. They can be localized only to one part of the vertebra, or they can be extensive, involving even the posterior elements. On the other hand, there is a type 2, which is a non-inflammatory, which is a stress fracture. You have the apex of the thoracic kyphosis like this, and there is a constant stress element. A moment arms on both sides are long, rigid lever arms. They are constantly bending. Stress is being given to this apex. Eventually, the apex, which if it is bone is osteoporotic, gives up, and the injury starts from the back to the front. So the posterior column fractures first, then the injury goes across anteriorly, either through the disc space or through the vertebral body. Typically seen in the lower thoracic spine or thoracolumbar junction, always extends into the posterior column, is usually solitary, and is always extensive. The pathogenesis, as I said, it could be either an inflammatory lesion as seen in image A, or it can be a traumatic lesion or as an stress injury, which is type B or type C in image. And all these have a common endpoint pathway wherein it forms a pseudoarthrosis, where there is a gap, there is sclerotic bone, there is hyperplasia of bone with new bone formation is what you would find. And as you can see in the MRI image here, often you would find fluid in the anterior cleft, and therefore these can be mistaken, as Ankur mentioned, as being infective. And I have also, like Ankur, seen a number of patients with this kind of an injury being treated with anti-tuberculous treatments in the wrong notion that this was in fact an infection. The question is, are there any more investigations that we need? Would you consider non-operative treatment over here, or would you think of surgery? Sashin, how would you proceed in this particular patient? She has new onset pain. It's quite severe and disabling.
Is obviously demonstrating mechanical issues. Pain is demonstrating what her problem is. And you've shown it on the MR and the X-ray, what's going on. So purely from a mechanics point of view, she would need stabilization. You'll have to go at least 2 or 3 levels up and down to stabilize it.
Which brings me to the second question, Sashin. Is there any role for the halo vest in this, like you had done in your patient? Or is there any role for any kind of conservatism in this kind of patient?
This is more of a chronic thing. It's not an acute. Trauma is different because this is telling us that this is more like a SUD. So that's slightly different to what an acute injury would be. So there are two separate entities in my view. So I would think completely differently for each one of them.
Right. Okay. So as Sashin mentioned, the natural history of Anderson's lesion is that it's an established pseudoarthrosis and therefore unlikely to heal spontaneously. There are long lever arms on either side which transmit all the mobility to the site of the lesion, resulting in persistent pain, possibly progressive deformity, and occasionally a neurologic deficit. There is a paper which I read from a few years ago, which says that pain may settle down after 2 to 3 years of conservative treatment. And if the patient is not ready for surgery, that is something which can be considered. And in this paper, they had mentioned that the various non-operative treatment measures were bracing, halo vest, and trying anti-osteoporotic agents like teriparatide. However, in our experience, as Sashin mentioned, there is no significant benefit. The question is, if we are thinking of surgery over here, Sashin, let's just start with you. What would be your approach? Would it be an anterior approach that has been described, a posterior surgery, both anterior plus posterior, or would you take this opportunity? I mean, it's occurred at the apex of the kyphosis. Would you take this as an opportunity to correct the deformity?
With my experience, what I've seen, I would do a posterior. From an osteotomy point of view, most osteotomies that I have done have been below the conus. This looks like more lower thoracic at the cord level. I would be very wary of doing an osteotomy at the level of the cord. Cervicothoracic junction is slightly different, but in the mid-thoracic cord, I would not want to do an osteotomy. If this was lower down, below L1, L2, then it's a different story. But if you look at that, kyphosis doesn't look that bad, although we don't have a long whole spine X-ray to demonstrate what the exact spinal alignment is. So I would just go posterior, fix it in situ, just up and down. If need be, we can always do an anterior later on to supplement if required.
Right. Ankur, we mentioned, would you agree with Sashin that you would do a long posterior over here?
Yes, sir. We'll go for a long posterior, yes.
In situ fusion, right?
In situ fusion.
Sashin mentioned he would not like to do a thoracic osteotomy over here. Would you consider doing a lumbar osteotomy to supplement, you fix the fracture as it is in situ, but do a lumbar osteotomy to correct the deformity in this patient?
So I think, sir, this decision is a very patient-based decision. The patient has not come to you for the deformity correction. He has come with an Anderson lesion and pain. And so you can have a discussion with the patient whether, the pain is the only reason he has come, and, is he really bothered about the gaze problems does he have? And then you can take the opportunity to do it for sure. But having said that, we have seldom done this, that we have taken the opportunity to use the fracture as deformity correction. It's not something we have seen as a common scenario.
Ankur, we did talk a little bit about what is your typical workup in a patient with ankylosing spondylitis who is going in for surgery, whether it is for deformity correction, whether it's for an Anderson lesion. In a fracture situation, of course, it's different because it's an acute situation. You may not have the opportunity to work up the patient that extensively. But what are the things that you are concerned about when you see a patient with ankylosing spondylitis?
So in a patient who of an ankylosing who has come to you for looking for a surgical option, that means he's either come to you for an Anderson lesion, or he has come to you for deformity. For a deformity, I think the first thing we immediately start looking at is at the hips. We start looking at whether there is a deformity which is coming from the hip, and is it correctable at the hip level or not. And more often than not, we have seen that there is a partially the deformity may be because of the hip, or a major part of the deformity may be coming from the hip. So the hip needs to be ruled out. And if they are fusing and causing the deformity to happen, probably it's a good idea to get your arthroplasty colleagues in and get the hips replaced. Having said that, if the hips have been ruled out, then we, for a deformity correction, we start looking at the various angles, the positive sagittal imbalance, the chin brow angle, the frontal gaze. And after assessing completely, then the decision whether we are going ahead for a what level of osteotomy we are going ahead. Usually we like to do, as Dr. Sashin said, below the level of conus, either at an L2 or an L3 PSO sort of situation. Yeah, so this is how I would think to approach a deformity guy.
Yeah. So, the basic concerns here is not only the spinal deformity, there is a problem in the hip, there can be problems in the shoulder, which may be stiff. So you positioning the patient may be difficult. So that is another consideration. The temporomandibular joint may be stiff. So intubation may be difficult. You don't want the anesthetist to extend the neck during the intubation. So preferably they should be doing a fiber optic intubation so that the extension is avoided. You need to look at the chest, look at the pulmonary function, because all these patients have a rigid chest, and therefore the expansion is restricted. They are more at risk for going on post-operative ventilators. You need to look at the GI, because they've been on anti-inflammatories for years, and that may have caused stress ulcers, etc. Plus, if they have a significant deformity, the stomach may be cramped and they may not be, their nutrition may be poor. You have to look at the kidneys, because these patients often have, because of chronic abuse with anti-inflammatories, they may have kidney issues. You need to look at the bone quality, because a lot of them have osteoporosis. So these are some of the things that you look at in the pre-operative picture as you plan your surgery. These are some of the things that you look at. Now, having looked at this, Sashin, you did talk about positioning earlier this patient. Now, this particular patient who has this kind of kyphosis, how do you position your bolster so that the patient can be adequately placed so that the anterior part closes down? How do you use a bigger bolster at the top, or bigger bolster at the bottom, or both the bolster of equal size? Do you break the table? How do you actually try to get a closure in the front?
Are you talking about this specific patient? This X-ray that you're showing?
Yeah, this X-ray, even for that matter, this may not have that much of an issue here, but even for that matter, the patient which Ankur talked about, how would you have positioned him in order to achieve an ideal?
I wouldn't have relied completely on positioning to correct, because you may not be able to. You may have to correct it intraoperatively with your metalwork. This one fortunately doesn't look that malaligned or that open. And maybe if you're so concerned about what you may or may not get, as you said, this is more of a chronic presentation rather than an acute presentation. You could take the patient to theater, put them on a table and see how they are lying down. Are they comfortable enough? That gives you a good opportunity to check everything out. Looking at the kyphosis that this patient has, of course, you need a full length X-ray to comment on it. But this positioning for them is always challenging. And Ankur quite rightly showed how their head falls forward. And you need to have that ability to keep that position right, and you've got to adjust and accommodate whatever you can. You may have to improvise with every little thing that you do.
Right. Thank you. So that's essentially the thing, the positioning, some of the important things being that you must have 7 or 8 people around you to help you turn the patient around. The patient should be like a log rolling, so that you don't end up getting fresh fractures anywhere with your positioning. Make sure you don't hyperextend the spine. That's another small tip. There are a lot of pressure points in the ankylosing spondylitis patients which you have to protect. in order to prevent pressure sores, etc. And once having done that, generally, if there is a significant kyphosis, I tend to break the table a little bit in order to help me to close the anterior defect, and then we go in. Ankur, challenges intraoperatively in terms of surgery in this patient. Firstly, in terms of exposure. Secondly, in terms of fixation. Here, of course, we are not planning any decompression, but in case you are planning a decompression, what are the challenges in an ankylosing spondylitis patient?
So I think, sir, once we have gone through the positioning, the challenges don't end. We know that every step is going to be challenging. So the tissue is quite fibrosed. The muscles are something which really do not retract like in a special in any other patient. And so the patient in an ankylosing spondylitis is much likely to bleed more. It's difficult to dissect the tissues out. Also, an important probably learning tip would be, because the spinous process and the interspinous ligaments are ossified, you have to be careful in dissecting the muscles of the spinous process, because the tip of the spinous process is expanded. And one of the common mistakes which usually we do in the earlier days is that we start cutting through the muscle, and it adds to the bleeding because you cut through the muscle in that case. So it's important to get under the spinous process and lift off the muscles completely. At the same time, the bony landmarks are completely lost. So, if you rely on your entry points regarding, how to put a pedicle screw, probably bony landmarks are lost. The visibility on the radiology also becomes a big issue. The CM is not able to show exactly the starting points. And, because of the positioning challenges, it may not be so easy to get the CM in a lateral position and then, be able to see the osteology very perfectly. So not only is the exposure a problem, the bleeding is also a problem, and as well as the CM imaging also becomes challenging. On top of that, your anesthetist friend, because you have positioned them on their tummy, plus their respiratory reserve is not so good. So there is always an increase in the abdominal pressure, which can cause increase in the bleeding and rise in the EtCO2 levels. So you have to constantly keep monitoring that as well. Decompression again is a different different ball game in an ankylosing spine, because very often the dura can be ossified, and when you do a laminectomy in a standard way, you may end up biting the dura without realizing that actually it is stuck up with the bone. So you have to be very, very careful. Avoid using your Kerrison rongers as freely you would use in any other patient. Using a high speed Midas burr would help in sort of identifying early if the dura is ossified, and probably you can get away with it. So I think these are some challenges which immediately come to my mind.
I think you've fantastically covered everything, Ankur. Most of the things, exposure, bleeding, all these are big issues. Identifying your landmarks. So I always do these screw fixations under CM control. Don't try to be brave and try to do everything without CM, do it under CM control. Even your starting point, you can look it under CM and then plan it rather than trying to do it after you. So these are some of the tips that you should be taking. As Sashin mentioned, the posterior cortex is often very nice and hard, and you get a feel that you're going to get good bone. That the moment the screw goes into the vertebral body area, there is no hold. So all these are issues which you have to deal with when you do this kind of fixation. There is the bone, even on the lamina, sometimes an interlaminar bone is very thin. So if you are to be very careful when using your cob, if you use it a little strongly, it can fracture and you can go and hit the dura. And there are lots of adhesions between the lamina and the dura. If you're going to decompress, that may be an issue. So anyway, going to the various surgical options over here, the anterior surgery was done. It was reported way back by Fang in 16 patients with 18 lesions. They found that there was solid fusion in 10 out of their 16 patients, but they said that there was a limited ability to correct deformity. The bone anteriorly is weak and osteoporotic, so there may be poor purchase of anterior screws, and there is a higher pulmonary morbidity, and therefore today anterior surgery is not the most popular. After the anterior surgery came in the posterior plus anterior surgery. So people started thinking that if you do a posterior surgery, it's not enough, you have to fill up the anterior gap. and which is left, and therefore people started doing posterior plus anterior surgery. And as I mentioned earlier, some people also use this opportunity to do an osteotomy and correct the deformity. What I did here was that I went in from the back, stabilized. This was in the very early part of my career in spine surgery when I started practice in Bombay, probably within the first year or two. So I went in from the back, stabilized it from the back. I got, as Sashin mentioned, the deformity was not so bad. And I got a fairly decent correction just with positioning the patient. But there was a slight anterior gap. I was a little worried. So I did take her up for a second operation and I did an anterior fusion. But when I went in there, I could hardly see the gap. So probably that was the time I learned that anterior fusion is not really necessary if you fixed it at the well from the front. Because when I got there inside through a transthoracic approach, what I found was that the intervertebral gap was so small that the size of the cage was practically about 2 to 3 millimeters. That was the time what I used. This must be probably way back in 2004 or so. Subsequently, of course, there is the group from the Lilavati Hospital in Bombay who published 18 patients with Anderson lesions, all treated simply with a long stabilization and fusion, and excellent results over long term without having to do an anterior fusion. They said a pseudoarthrosis voids less than 2.5 centimeters were seen to heal spontaneously over a period of 1 year. There are other papers who have reported that along with the fixation posteriorly of the Anderson lesion, they have also used this opportunity to do a lumbar osteotomy and correct the deformity. This is one of our other cases. 45-year-old male fell off the staircase 3 months ago, severe back pain and progressive deformity. You can see that he had developed a pseudoarthrosis over there. He had a hugely hypertrophied facet joints at the back, which were causing mild compression, but there was no neurologic deficit. So this patient, we took this opportunity to do a correction at that level. When we positioned the patient itself, the thing opened up and we were able to stabilize from the back, and then went in at a second stage from the front and fused the spine. You can see the significant correction of the deformity in this patient. So the take-home messages here are very clear. Beware of new onset pain in patients with ankylosing spondylitis. It is fairly common and it is commonly ignored by most doctors. And if you have a patient who's complaining of mechanical pain, which is of new onset in patients with ankylosing spondylitis, please image these patients with a CT scan or an MRI scan, because diagnosis is often missed on plain X-rays. These are usually unstable lesions and can cause progressive deformity. The treatment as of now, the current situation is posterior long segment stabilization. Generally, if the deformity is not too bad, in situ or else with deformity correction. Thank you. Any comments, Sashin, on the 2 cases that I presented?
No, you can see how challenging things can be. Yes, I agree with that, that we need to consider long stabilization. Is that photograph where, the bottom left, is that when you put him on the table for a trial run to see how he would be on the table?
Yes.
Yeah, but that's a good thing to do, isn't it? He's awake and you can easily see how they would be, because at least you can see how much you're stressing the body, how much you're stressing the spine, how much it's going to take, and what it's going to do for the patient.
Ankur, yes, you want to
Yeah,
make?
so I just wanted to ask, sir, have you done this front and back as separate procedures, or did you do it all posterior? Because it's a fantastic correction and it's very nicely done, sir.
So this was done front and back.
Front and back. So you
At the same sitting, unlike the previous lady
sir.
who I did in 2 sittings. I did a back first because I had not planned for an anterior surgery. And then I went in and I took their consent the next time and then went in anterior. Here it was a planned situation. We did both of these things at the same sitting.
So you did first posterior and then anterior, or?
That's right. Yeah, first posterior and then.
Great. Okay, sir.
All right. Thank you very much, gentlemen. Thank you To all our delegates who have been patient and have attended this seminar, I would like to thank Mr. Sashin Ahuja, who was my senior. He was my registrar when I was a houseman in orthopedics and is now a very popular and famous consultant spine surgeon in Cardiff, Wales. I would also like to thank my young colleague from the Indian Spinal Injury Center, Ankur, who have presented a very, very difficult case, which I'm sure would have flummoxed most of us. I would like to thank the Association of Spinal Surgeons of India for giving us this opportunity to be here, and for Thieme Medical Book Publishers for organizing and assembling this crowd today. I would like to again stress to the audience here that the Association of Spinal Surgeons of India came up about 2 to 3 years ago with a bunch of monographs on spine surgery. We have 9 monographs. They include on lumbar disc prolapse, lumbar canal stenosis, early onset scoliosis, osteoporotic vertebral fractures, also on ankylosing spondylitis, complications in spine surgery. We have a monograph on safe spine surgery, and I would encourage all of you to read and go through that. They will be extremely valuable to you in your practice. ASSI is very proud that we've sold about 16,000 copies in total of all these together. So with that, I would like to thank Sashin. I would like to thank Ankur again. Any final comments from you, Ankur, before we stop?
No, sir, but just wanted to thank, the Thieme publishers and Dr. Gautam sir for, having us here. And it was great to hear Dr. Sashin sir and his, experience with ankylosing, which is a little bit, different from the Indian scenario, but it's been great learning for me as well. Thank you so much, sir.
Sashin, some final comments here?
No. Thanks very much for the invite. I think the message has come quite through that these are challenging cases to treat, and just remember all the salient points that we've covered. So thank you very much.
All right. Good night, gentlemen. Hope to see you again at some other seminar soon.